Hello, everyone, and welcome to my favorite topic, data-driven goals for the health neighborhood, the last of 5 webinars in the second round of an ongoing training series offered by the Behavioral Health and Wellness Program in partnership with the Arizona Department of Health Services. We have a lot of material to cover before, and I know that I say that every time, but I think this is the truest that it has ever been. So much so that I've cut my personal introduction and I've cut the housekeeping slides. You know who I am and you know the drill. You can use Q&A and chat to get me questions while the webinar is going on, but unless absolutely necessary because the sound cut out or I've used an unfamiliar abbreviation or something, I'm gonna keep going until the end, at which point you can continue to get your questions to me via chat or Q&A, or you can use the raise your hand function and we'll unmute your line and you can ask your question that way. Today's presentation is divided up into 3 parts. In part 1, I want to talk about some major sources of our national and statewide prevalence rates and the difficulties of using them in our program design. Prevalence rates are useful, but we need to know how and where they're useful for us so that we can use them appropriately and not set ourselves up for failure. I'll be exploring to a degree national data, but I will highlight these difficulties and opportunities by looking at Arizona's prevalence rates. However, these and related words of caution can be applied to the national smoking rates among incarcerated individuals that I'll bring up in the second section. And in that second section, I want to move out of smoking prevalence rates and into the data that can best inform your program design, surveillance, and evaluation. There are countless variables that we can choose to measure. Our choices are limited by our, our resource capacity, and they're also influenced by our theory of change. And finally, very rapidly at the end, I want to talk about some resources that you can access to augment and refine your thinking of the programs that you're designing. I want to start today's presentation by putting prevalence rates into context. They are useful, they are important, but we cannot measure the success of our local, regional, or even our state level programs based on whether or not we see any movement in prevalence rates. According to the last Arizona Tobacco Program biennial report, there are about 740,000 adult smokers in Arizona. The Arizona Ash Line runs statewide. It's open 24 hours a day, 7 days a week, with the exception of a handful of major holidays. It offers a variety of services that are free to the caller. And despite all of this, it provided services to only about 7,100 Arizona smokers the last time that they reported to NAC, the National Quitline Consortium, North American Quitline Consortium. That's a rounding error from 1%. And if we figure an upper end success rate of about 30%, then of those 7,100 Quitline users, about 2,100 will have probably quit. There are roughly 44,000 17-year-olds in Arizona right now that will turn into 18-year-olds next year, about 8.5% of which will be smokers. That's 3,700 new smokers. Now, I'm not saying any of this or bringing any of this up or highlighting this to disparage the Ash Line in any way. In fact, my point is precisely the opposite. The Ash Line does a great job. The fact that the numbers presented here, it won't necessarily in isolation be reflected in the statewide prevalence rate is irrelevant. I'm bringing it up for one reason and one reason only, to point out that looking for changes in Arizona's statewide prevalence rate year over year is not a good measure of whether the Ash Line by itself has been successful or not. But the prevalence rate is useful even to the Ash Line. It helps ADHS and the Quitline contractor to estimate how many calls and referrals they can anticipate and how much inter-T they will distribute. This helps immensely in making sure they have enough trained coaches available, and along with other demographic data, can help them determine what specific protocols and tailored programming should be prioritized as they design their annual training curriculum, and so on. To judge the Ash Line's success, we need to consider alternative metrics. For example, their quit success is very high. And on top of that, many of those 2,100 callers who use the Ash Line to quit will have had access to no other resources. Many of them needed more support than they would have otherwise had available to them without it. Which is to say that out of context, 2,100 maybe doesn't sound like a lot, but when we consider they're getting a good quit rate with an audience typically of older women without college education and disproportionately reporting mental health issues, well, suddenly we can see that that 30% quit rate is really reflective of 2,100 individuals who would likely not have been able to quit without Ashline support. And while the numbers I used above imply that Arizona is fighting a losing battle against smoking prevalence, this is obviously not the case. Prevalence rates in Arizona are among the lowest in the country, and they've experienced year-over-year decreases in their prevalence rate. That's because the Ashline does not operate alone. They work side-by-side programs like yours. Quit lines around the country are the first to tell you that they do not and cannot work alone. They are care extenders, and the care they are extending is the care that you are providing or attempting to support with your programs. So with that in mind, if we can't expect to have a visible impact on the statewide, let alone the national prevalence rate, how can we use the prevalence rate to inform our program design? So we start here with a simple question. How many adults smoke? And that seems relatively straightforward. And in fact, we have 3 nationwide survey instruments to attempt to try to answer it. They are the Behavioral Risk Factor Surveillance System. We call it BRFIS, and that's what I'll continue to call it from now on. The Tobacco Use Supplement to the Current Population Survey. That's an extension of the census. And the National Health Interview Survey. And they each tell us something different. But how different are they? Well, sort of straightforwardly, pretty different. The difference between 16.1% prevalence and 14.4% prevalence is, if we were to apply it to Arizona specifically, roughly the difference between Arizona's 2017 prevalence rate of 15.6 and its prevalence last year of 14.0. But we can't really compare prevalence rates across studies that use different methodologies, are conducted at different times, and also use, frankly, different definition of who is counted as a smoker or not. Depending on your program goals, any of these might be more applicable to your program than the others. For example, if you're working with other census data to inform your program goals, then the tobacco use supplement might make the most sense. You're going to get more accurate crosstabs using the smoking prevalence rate determined by the census and comparing that figure, for example, to respondents who are also using supplemental nutritional assistance, which is also tracked by the census. By contrast, if you are designing a whole person wellness program of which exercise, servings of vegetables eaten per week, and smoking status are all integral, then perhaps the National Health Interview Survey is going to be more appropriate. In point of fact, while these numbers look pretty far apart, if we consider the confidence interval, and don't be scared, I'm not going to get too statistically wonky today, but if we do consider the confidence interval around each of these numbers, the difference starts to get mitigated a bit. BRFIS does not provide a 95% confidence interval around its national figure, but it averages about 2 points or so within each state. That's plus or minus 1 point from the number you see there. The National Health Interview Survey has a 1.3 spread, that's 0.65 in either direction, which is to say that the true National Health Interview Survey value could be as high as 15, while the low end of the BRFIS estimate is 15.1. Not the same, but not all that different. I want you to have 2 takeaways from this slide. The first is just to pick the prevalence rate that makes the most sense to you and truly understand how they got their figures and what the limitations of that instrument are. Critically, remember to note which one you're using and which year the data were gathered. We can often ignore the fact that newly presented prevalence rates are actually snapshots of a year or more before. But when we're using these figures to benchmark our program's success, it can really muddle the picture. The number often referred to in short as, for example, the 2019 prevalence rate, is really reflective not of what people were doing in 2019, but what people were doing in some number of months 1 or 2 years before. If you want to compare the success of your program that's running in 2020, then you can't compare it to the numbers you see in 2020. The national numbers you see in 2020. The proper comparisons are the numbers gathered in 2020 while your program was running and you were also gathering your numbers. This is important because depending on the trend line nationally, your program may look better or worse in comparison to the wrong year. The other big takeaway is that I am strongly suggesting that you consider using the BRFIS figure and adopt its standard of the definition of smoker. There are multiple reasons for this, but the 2 biggest ones are these. It has the largest sample size and therefore is probably the more accurate figure. Also, it's conducted at the county level under state level guidance or supervision, which is to say that if you're working directly with state government counterparts, if you use BRFIS, they will understand what you're saying. I will continue to use BRFIS for the next few slides, but also bear in mind that although I am right now suggesting that you use BRFIS, BHWP, because we are a whole person wellness program working in nutrition and sleep and stress and other dimensions of wellness, we use the National Health Interview Survey figures. So you can take the previous advice with as big a grain of salt as you need to. Generally speaking, if your primary government contact or a supporting agency is your local public health entity or your state public health entity, the stat you want is the BRFIS one. So here are the tobacco-related questions on BRFIS, and I know this slide is ugly, it's busy, it's hard to read. I'm not gonna go into all of it, I just wanted you to have access to it in your notes. So here are the things you need to know. A yes answer to question 1 triggers the second question. And if the respondent says to that second question that they do smoke on some days or all days, then that's how they're defined as a smoker. On a slide coming up, I will continue to differentiate between everyday versus someday smokers, but know that a smoker, by definition, is either response. Also note that a yes to question number 3 is how BRFIS and BHWP defines a quit attempt. 24 hours without tobacco with the intention of becoming quit. That's a critical phrase, which is to say that a smoker who goes into a coma, or a smoker who gets admitted to a hospital, or a smoker who gets incarcerated into a smoke-free jail, none of these things count as a quit attempt. And finally, the final 3 questions, ones that have a different color. These are part of a recently added lung cancer screening section to BRFIS. They're only asked of people whose smoking should trigger a cancer screening, that is, smokers over a certain age. It was added a couple of years ago to see how many individuals eligible for a lung screening were getting one. It has not yet been deployed to every state, and I don't think it's been deployed in Arizona yet. I'm adding it here so that you can be on the lookout for it later, as I can see these being an interesting program design solution. I'll be returning to BRFIS in Arizona in just a second, but I want to talk about one more issue in regard to prevalence rates. In addition to being uncertain, shown here with the gray shaded area, there are also averages. It doesn't tell us anything about the entities that were averaged. So here we see that over the last 50 some odd years, prevalence rates have gone way, way down. But they have gone down, but have they gone down the same way everywhere? We do know that there are state level differences between prevalence rates. It stands to reason that declines have also not been experienced at the same rate. And differences don't stop at state borders. In a recent analysis I did for Colorado, I found that there are 4 Colorado counties with prevalence rates lower than Utah's, and 4 counties with prevalence rates higher than West Virginia. The range of diversity within Colorado actually exceeds the range of diversity in the country writ large. I suspect the same will be true in most states. Okay, whew. So I'm gonna switch gears a bit and now dig into Arizona's prevalence rate and try to use some patterns and some domain expertise to try and show how I use high-level data to extract useful programming information. Pictured here are 4 smoking trajectories identified in a recent longitudinal cohort analysis. And just because it might be a little bit difficult to read, I'm going to refer to some of these terms later. You'll see the blue line are called experimenters, the orange line is called quitters, gray line is called early established smokers, and finally the yellow line is called late escalators. We tend to think of smokers as all being more or less the same. In fact, most people, if asked, will tend to, they seem to carry around a baseline idea in their head of a quote unquote pack-a-day smoker, and that's our definition of a smoker. In fact, the volume of cigarettes smoked per day is multimodal, right? People tend to gravitate toward 5s. 5, 10, 15, and 20 cigarettes per day are all really common figures. The average number of cigarettes per day is actually 16 to 17. And on this graph, we can see that, at least in this cohort, that even everyday smoking isn't the average. Now, I do want to point out real quick that this is one of those figures that are subject to a weird statistical quirk, which I like to illustrate like this. The average number of legs per person in the United States, and yes, if your mind was wandering, I am not talking about the average number of legs in the United States per person, is something like 1.8. Because while there are some people with 1 or 0 legs, there are very, very few with 3 or more. So the average mathematically is going to be lower than 2. Similarly, many smokers can smoke 12 or 15 or 20 days per month, but nobody can smoke 32 or more days per month. So mathematically, the the average number of days smoked per month has to be below 30. Still, it's interesting that enough people under 30 years old smoke less than 30 a day, or I'm sorry, 30 days per month. So they smoke at such a smaller rate that it drags the peak down not to 29 or 28 or 27, but actually down to, it peaks at 24, and throughout the decade of the 20s, it actually decreases even further. So let's take this information and apply it to Arizona's prevalence data. Yes, okay. Sorry, I read the question. I'm definitely going to answer that question at the end. I just wanted to, I distracted myself. Okay, so I'm going to be returning, whoops. Okay, I'm going to switch gears a bit and now dig into Arizona's, nope, I already did that. Okay, so the slide I want to show you, sorry, is coming up, but I want to help you see it clearly when it shows up. There's a dip in the data. You see that right there in the 35 to 44 cohort, the third bar from the left. So this strange dip makes it harder to see the story that I want to tell, but this dip is illustrative of my previous point of beware of confidence intervals. So I left it in, but I don't want it to muddy the chart too much. The chart I'm going to show coming up next continues to use the 4 Burfus categories of everyday smokers, someday smokers, former smokers, and never smokers. Never smokers are on this chart alone. So in point of fact, the number of never smokers can never go down over time, right? I'm sorry, it can never go up over time. It can never go up unless a gigantic cohort of smokers suddenly arrives en masse to the state. But we can see that it is indeed what happened here, right? So never smokers has to keep going down. So this weird little dip in the middle where it goes down and then goes back up is what's weird. That's what we're trying to explain here. Now, it could be the case that something happened to this cohort where just a bunch of them picked up the habit in the 4 or 5 critical years. It's also possible that a gigantic group of smokers did descend into Arizona. Arizona is one of the fastest growing states, and that can do weird things to cohort data. But the most likely scenario is just the confidence interval. As a reminder, I know I said I'm not going to get too statistically wonky, but this will be, I think, the last time I say anything like this. As a reminder, the 95% confidence interval is simply a recognition that statistics contain some uncertainty and survey results are what they are. But when we try to infer from the sample what may be true about the population, the confidence interval simply says that we're 95% confident that the true value is contained within a certain range. And that range is depicted by those black bars on this slide. And for this particular cohort, the confidence interval is anywhere inside this orange box. And if we look, and when confidence intervals overlap, we say that those 2 figures are not statistically significant from one another, right? So if we look where this box overlaps other confidence intervals, we can see that the 35 to 44 cohort is only statistically significantly different from the 18 to 24 cohort on the far left and the over 65 cohort on the far right. And this is actually reflective of what we see in almost every state and of course nationwide. So, okay, with all that in mind, what I want you to do is concentrate on the red and rust colored boxes on this slide. This is the 2018 Burfus data for prevalence rates by age. The orange bars are the blue bars from the previous slide. Okay, so you can still see that weird dip in 35, 44 because that's exactly the same data. So thinking about our trajectories slide with the 4 trajectories, let's try to see how we end up with the prevalence rates that we have. So just as a reminder, you have to do some on-the-fly arithmetic. The smoking prevalence rate is the result of adding the rust-colored and green-colored boxes, like so. One thing that should jump out at you is that when we talk about Arizona's, quote, adult prevalence rate of 14%, what we really mean is an adult prevalence rate of 16.2 or higher. Seniors and young adults smoke at just over half the rate of the other age groups. You will note that the prevalence peaks in the early adults, drops, and then rises into late middle age, drops again, then drops again. That's the sort of pattern I wanted you to be able to point out. So comparing this to the trajectory slide, or sort of adding that information in, what you're seeing is the formation of the habit well into the 40s. That is, the habit has not concreted itself in the way that we normally think of a quote-unquote smoking habit, with many of the experimenters and quitters leaving the habit along the way. And then as the decade of the 50s progresses, chronic diseases develop, and we start to see the effect of active cessation attempts and, tragically, early death. The cliff at age 65 is the result of about half of remaining smokers quitting during the previous decade and half of them dying before their 65th birthday. So now we're starting to see how we can use some pretty high level statistics to start modifying different strategies of reaching different individuals. Age is not the only way we can divide up our statewide statistics to develop more tailored initiatives. For just one example, but if you are using age, one example, one thing you could do is if you're working with individuals older than say 40, 45, you may have a lot more full prime for a quit attempt than you might otherwise know or suspect. So gearing your educational initiatives away from what is nicotine and other tobacco 101 modules and toward how to mitigate and manage cravings may be a more effective educational solution. Whew. So that was a lot on prevalence rates. The rest of the presentation is going to move a lot faster. So in my the last webinar for this community of practice, I presented this slide where I emphasized the critical importance that any data you collect should be actionable, lest it be considered and actually be a waste of our most valuable resource, time, and our second most valuable resource, which is our partner's willingness to do the thing we want to measure. What I'm going to do in a bit is talk about 3 broad initiatives, but before I do that, I want to, before I dive into those initiative types, I want to say a word on these 2 broad classes of data, process and outcomes. In order to create a good benchmarking and evaluation scheme, you have to have a theory of how each step in the process positively or negatively influences each subsequent step. And there are 2 broad ways to measure each step. We can count that they happen, and we can count the quality of the performance, which may include things like who performs that step, or when in the client encounter it occurs. For example, we could engage in passive referrals to the ash line, which basically means we set out brochures for people to browse. At the end of some time period, we count how many we're missing and how many individuals were referred to the ash line from our site, presumably because they asked for a referral within that same time. Or we could screen for tobacco use and refer users to the ash line directly. In both of these scenarios, we have an outcome, the referral to the ash line, but we have 2 different referral processes. If we ran both versions for a little bit, we could then look back and test the differences. Maybe the more active version, the one that BHWP recommends, gets both more referrals and more enrollments, but as a proportion of referrals, maybe the passive version gets more enrollments. So what's my point? Well, depending on your theory of change, you may decide that the quote unquote outcome that's most important is enrollment. So you want to do the thing that gets you the most enrollments for the least effort. Or maybe you think, as we do, or quit lines do, that the most important thing is the referral. So that's the outcome of choice. Or maybe you think that just making sure the client is aware of their options is the best thing. So screening or brochure counts are the correct outcome. If you can be reasonably sure that handing out brochures leads to better quit outcomes, then you can make that your program metric. Now, I rush to say that I disagree with that, and that's the point. The only outcome that matters is that clients quit and that their health improves relative to if they had not. Everything else is a process. But it's also the case that each subsequent step in the chain is an outcome of the previous steps. So better screening is going to lead to more advice to quit is going to lead to more quit attempts is going to lead to more successes. So following from that, I want to offer 2 pieces of advice. First, try to measure what you are actually doing, your program is actually doing. Like, don't just measure who shows up to psychoeducational groups. You aren't doing that. The person who shows up is the one showing up. If shows up to group is an important metric, you need to measure what you are doing that influences whether someone shows up or not. And 2, try not to turn your metrics into targets. And this can get really, really tricky. In economics, this is called Goodhart's Law. Chad warned me not to get too academic, but this is just too fun not to mention. So if you want to look into this, you need to know about Goodhart's Law. In a slightly variable form in the social sciences, it's called Campbell's Law. I'll give you one non-tobacco example and one tobacco example. A few years ago, a good indicator of what the economy was going to look like a few months down the road was how to track how many boxes were being shipped from the box manufacturers, right? If they were shipping more boxes, it was because other manufacturers were going to need those boxes to ship their stuff to consumers. Voila, a tricky advanced peek at economic growth. Extremely valuable if you're an investor looking for a legal sneak peek at the future. However, once word got around that this was being done, then Amazon, as a purely hypothetical example, could signal to Wall Street that they anticipated a lot of new orders simply by making a disproportionately larger than normal order of boxes. In tobacco, we have countless such examples, but for purposes of illustration, I'm only going to provide one. We have the two questions on the heaviness of smoking index. One of them is, how many cigarettes do you smoke per day? Now, reducing the cigarettes per day enough can reduce a person's dependence score. And it's possible you might make, quote, reducing aggregate client dependence scores a program metric. I don't recommend that, and here's why. Reducing the number of cigarettes in isolation of other supports is not in the literature associated with long-term abstinence. Someone who is able to reduce their cigarettes per day probably has less physical dependence after reduction than they did when they smoked more, but physical dependence is less than half the story of ongoing dependence. We know that because even in laboratory conditions, individuals given NRT at the appropriate dose only succeed in quitting 25 to 30-ish% of the time or so. A lot of quitting is about the desire to do so, the confidence that one can do it, the social support networks they have, and the unique character of those motivations. Many people, when they step down their cigarettes per day, wrongly believe they have gained more health benefits than they actually did, which is to say that their motivating perception of risk gets smaller as their cigarettes per day gets lower. We know from the literature, as I mentioned, is that as people step down, they eventually hit a suboptimal equilibrium where they haven't quit all the way, but they think they've quit enough. Without coaching or counseling, this is where they stop. It's not entirely inappropriate to target physical dependence as a reduction goal. The risk is when we treat it as a target in isolation of how it interplays with the larger dependence matrix. Dependence indices are predictive because they describe the natural state of behaviors within those dependence tiers. If we try to manipulate the factors that determine the score, we get a new score without altering the underlying psychology, the underlying condition that it was trying to measure. Okay, so with that huge, long, broad caveat out of the way, let's look at some intervention types. And I'm going to begin with the most common. In its broadest terms, it's believed that education can, in isolation, change behaviors. A rapidly developing field of cognitive learning is offering convincing evidence that this simply isn't true. At best, education has independent effects on both attitudes and behaviors, and that changes in attitudes can also contribute to behavior change. But an individual's work, home, and social environment imposes a separate and sometimes countervailing effect that is often more powerful than what education alone can exert, which is to say that education per se only acts on knowledge, which has an indirect and inconsistent impact on attitudes and a diluted impact on behaviors and does not impact the environmental constraints at all. We can complicate this further. I know that you enjoy me complicating things further. And we can complicate this further by noting that it is rarely the case, especially in the realm of tobacco cessation, that the education you're able to provide, is entirely new. So your ability to create entirely new behavior patterns is further restricted by the fact that whatever the magnitude of the effect on behaviors new knowledge can exert is going to be dampened by the fact that not all the knowledge is new. And yet the person still has not adopted the behaviors they're hoping to see. Which is not to say, I'm not advising that you abandon education initiatives. Health education is a fundamental and critically important role. It's the role I'm performing right now. My point is twofold. Measure what you're doing. If you are educating, then you should measure whether things are being learned, not whether behaviors change as a result. To the extent you want to impact behaviors, and I think you should, and you want to impact behaviors through an educational component, then we still need to do two things. We need to look for opportunities where education is the reason people aren't performing that behavior, and we need to do some detective work to figure out if other initiatives would be more productive in changing behaviors if we were to supplement our education with them. And I'll show you a bit of how we do that at BHWP. So this is one slide from a very large assessment that we did of a clinic here in Denver, in the Denver metro area. We gave them 2 survey instruments. This is a pretty common protocol for us. One is what we call the organizational self-assessment, and the other, from which this is pulled, is called our knowledge, attitudes, and staff knowledge, attitudes, and behavior survey. In the newest iteration of that study, we asked staff to tell us if they ever received any formal training on different tobacco cessation services and how comfortable they would be performing them. You can see here that most of the tobacco cessation services we ask about appear in that upper left quadrant. That's the quadrant where the respondents feel comfortable performing an act on which they have received no formal training. Some of those make sense, like checking uses tobacco on the patient's electronic health record is not going to require an hour-long course, right? But others really do need at least some training to ensure the quality of service is as good as it can be. At any rate, what this graph shows, or what this graph shows me, is that this is a staff who could really benefit or potentially benefit from a formal tobacco fundamentals training. Their apparent comfort performing the task tells me they are willing to do a lot of these, and that education is perhaps a primary barrier. But we still need to know more to make that determination. What I would do from here, and what I did in fact do from here, is compare this to the behaviors scale from the second part of the survey, or the third part of the survey, sorry, and look to see which of these things are being done and which aren't. Those things that are being done, then I want to, that shows me that there's some passion behind it, right? There's the passion behind that particular service, or maybe the whole tobacco cessation domain, but it's also an area where we can probably improve patient outcomes by reducing the variability of performance. And I'm going to return to that concept in just a second. I would then, after I looked at the behavior section, I would look at those things that weren't being done, and I would go through the organizational self-assessment, that other survey instrument that we give them, to look for institutional constraints, where somebody might say something like, well, we're just not funded to do this work, something like that. If I see high comfort along with some education, and these things are still not being done, then I'm going to really dig into that organizational constraint level. If I don't see that organizational constraint level, then I can be pretty confident that an educational initiative is going to make sense here. Okay, so there are a lot of different kinds of educational interventions. You could be educating in an attempt to prevent initiation. You could be educating in the hopes of empowering individuals to provide them with the confidence to make a quit attempt or to sustain one. You could, as on the last slide, be educating or training staff to perform certain tobacco-related functions. I pulled this slide from a presentation I give on implementing groups. It definitely applies there, because that's where it's from. But the general strategy has implications across the board and ties us back to that process and outcomes slide that I started this section with. Because the magnitude of our total effect on patient outcomes is reduced by each person that drops out at each phase of the process itself becomes pretty critical. So I always encourage organizations to think about their program rollout in phases, where the preponderance of benchmarks must be hit before one truly enters the subsequent phase. That is, you don't say something like, on August 1st, we will enter phase 2. That's not the kind of phase 1, phase 2 thing I'm talking about here. Rather, you simply are just in phase 2 when the conditions of phase 1 have been met. So to illustrate this with the group example, once you're in phase 3, and I just jumped to the end. Once you're in phase 3, you start to really look at changes within the mind of the attendees of the group, right? You're looking at whether or not they're gaining skills, knowledge, if skills and knowledge are translating into confidence, etc. But in order to assess the attendees' skills and confidence and knowledge, you have to have attendees to measure, right? And so then you return to phase 1. That's when you start at phase 1, and you'll see that the second and third bullets there are recruitment and attendance. These are really basic counts. I mentioned that you could count, counts are a metric, and quality is a metric. So in phase 1, we're really looking at counts on the client side. Then as we move through phase 2 on the client side, we start to try to get at some of their psychology. Are they enjoying it? Are they benefiting from it? And we can ask that question directly, right? We can say, do you like it? On a scale of 1 to 5, tell me how much you care. Or you can just look at how many sessions does each person attend, right? The more sessions they attend, the more likely it is that they actually are getting some benefit from it. And then finally in phase 3, we're no longer looking at our staff level metrics at all, and we're looking exclusively at clients. And here I say at the bottom there, longer term outcomes. Sometimes that's not possible. That's why we look at those other things, like did they actually leave our group or the group with additional knowledge, etc. these things are causally tied, or at least we suspect they're causally tied to longer term outcomes. So I know this has been pretty long-winded, but I do want to add this slide, and this is, Chad did not see this one, so apologies, Chad, if you're off there grimacing with that T-score and that P-score off to the side there. I'm not going to talk about them. Box plots are attractive and charming, and I love them. I recently finished a training of a group of Colorado pharmacists who have agreed to do tobacco cessation counseling sessions at their pharmacies, so it's a pretty big deal. We measured the pharmacist's confidence in performing certain tasks before and after the training that I gave. And we asked them to rate it on a scale of 0 to 10, okay? And so you can see here that not only did the average score, that's how much did you learn, basically, or how much more confident are you, I should say. The mean score increased quite a bit. That's what those things, and statistically significant. I just picked one question because it is sort of cherry picking to show you how awesome I am. But you can also see that the variability decreased by 1 point. I would have preferred a bigger reduction in variability, but it still illustrates the point. Which is to say that once you've been educating staff for a really long time, you're not going to be able to improve their mean knowledge score. You're not going to be able to move confidence that much once everybody is pretty confident. Once you start to hit that 7.5, 8, 9 confidence level, you're not going to improve that very much. But what you can do is start to look at the worst performers in terms of confidence or knowledge or whatever it is, and try to bring them up to the levels of your average performance or even higher. So you're reducing variability amongst different staffers. Okay, so now I want to finally tackle service provision. And to be clear, education is actually a service. And as I discussed in the first webinar in this round, most of what we call tobacco cessation counseling is in fact education and not what we would normally call therapy. Here what I mean by service provision is delivering the 5 A's. And because we have spent so much time talking about the 5 A's, I'm going to focus exclusively on the associated metrics of each A. One of the more frustrating aspects of deciding to work within criminal justice system is the sheer lack of good statistics about our population of concern. The national surveillance instruments mentioned in the first section, by design, exclude group living situations like residences, group residences or prisons and jails, residential substance abuse and psychiatric facilities. And instruments that do measure, say, prisons and jails, those are mostly housed within the Bureau of Justice Statistics. If you haven't been to that site, I recommend it. But they're really mostly just counts and some basic demographics. What race are they? How old are they? That kind of thing. We rarely get a sense of what they need, or even sometimes even why they're there. The data here and on the next slide were published, I believe, it was either 2015 or 2016, and they have not been updated since. I have not once found a single report that tries to estimate the prevalence of smoking within prison and jail facilities in aggregate. Rather, what we have are reports from individual facilities, and from those individual studies and reports, we can calculate a roughly 75 to 80, calculate that roughly 75 to 80% of inmates in jails and prisons smoke. And that's interesting for 2 reasons, that figure 75 to 80%. The first is that that number is super high. It's so high. The other is that those figures have held steady even as the general population rate has dropped. And to say that another way, or to illustrate that, or how important that is, with other populations of specific public health interest, say LGBTQ or English-speaking Hispanics, we say they smoke at 2 to 3 times the rate of the general population, or come up with some ratio like that. And as the general population rate increases, then increases or decreases, then the rates within those subpopulations also increase or decrease at that same rate, more or less. With the prison population, the 75 to 80% figure was true in the 1980s, when the general population rate was in the low 30s. And it's true now, as far as we can tell, even though our general population rate has been cut in more than half. So while in the 80s, smoking rates among incarcerated individuals was what we'd say 4 to 4.5 times as high as the general population, today we'd say it's closer to 5.3 or 5.7 times higher than the general population. This speaks of the multiplicative risks of smoking associated with individuals who will eventually become incarcerated, which we've discussed before, and which is a major reason BHWP feels this is a truly critical population that needs our attention. The other reason shown here and on the next slide is that smoking kills a lot of people. Jail populations are younger than prison populations, but already, even in this younger cohort, we're already seeing some of the outcomes of these higher prevalence rates. After suicide, heart disease is the biggest killer inside jails. Rounding out the top 5 top causes of death in jails, we see 3 more cigarette-caused diseases: drug and alcohol intoxication, respiratory disease, and cancer. This link between mortality in incarcerated environments and smoking becomes even starker when we look at prisons. Here we can see, as in the general population, that heart disease is our #1 killer. Cancer is 3rd, followed by a statistical tie between suicide and respiratory disease. This slide is pulled from a presentation that Chad and I will be giving on Monday for the National Council for Behavioral Health on quitline program designs. But again, the principles largely apply here and convert easily into metrics that we can use to evaluate health neighborhood-based programs. For example, while it would be best practice to ask every single client at every single visit their smoking status, in the health neighborhood in particular, the reality is that many organizations will choose a looser parameter, something like each client will have their smoking status updated in the client record at least every 3 months, as long as that person visits us within 3 months. Success is measured against this metric, however it's defined for you. So for example, if you see 300 unique clients every 3 months, you will divide the number of people whose smoking status was added or updated by the number of individuals who should have had their status added or updated by your criteria. Right now in Colorado, our MDs are able to ask about 80% or so of their patients at every visit, and that to me sounds like a decent starting goal. Now, that point, what I just said, that goes to our 4th bullet point, setting benchmarks. It's not always obvious what a good benchmark might be. For example, if I had not shared that Colorado physicians are asking about 80% of their patients at each visit, I don't know if it would be intuitive to have just written that down and said, yep, 80% is our goal, right? Instead, we go to the 2nd bullet, estimating your workflow. And from there, you can set your benchmarks based off what you think you'll be able to accomplish rather than trying to determine what is the quote unquote right target. Okay, so you've seen this slide before in the context of estimating your work burden. If your numbers look like these, and still assuming you see 100 people a month, give or take, you're gonna see 60 folks who want to quit within the next 6 months, some of whom are already in the process of quitting. So the question you have to ask yourself is, do you have the staff resources to make 60 referrals? Let's say it's just a referral program. Perhaps you've determined it takes 3 minutes per referral, but you only have 1 person who can be trained to deliver that referral to the standards you want them delivered. You may determine that you really only have the resources to make 10 referrals per day. So you can make 60 in a month, provided that no more than 10 show up in one day. Now, you could model this using electronic health records or other previously gathered data, or if you have a statistician on staff, you can actually make a pretty good prediction of what the likelihood of exceeding 10 referrals in a day is given only 60 eligible people per month. Or you could go my preferred method, which is to say 60 people in a month equals about 1 to 3 per day, but 100% success seems unlikely. So maybe you'll aim for 90% or 50, which is 54 referrals per month. Once you have your benchmark, that is the metric of success. If after some time you see both that 54 referrals is in fact 90% of eligible referrals, and also that this is a totally manageable number, then you can readjust your goals upward, right, from there. Okay, so, but in any case, it's pretty easy to support the decision to add or augment 5A's related processes, because the 5A's is an evidence-based strategy, and it is well documented in the literature that the more A's you do, the better outcomes, and that despite the robustness of that finding over time, we know that, say, physicians do the final 3 A's so little that there is barely enough research to study it in the field. You can kind of see that on this chart with all those NAs floating around. And while the 5A's has grown into medical adjacent sites like dentist offices and pharmacies, it has yet to make large inroads in community behavioral health, social services, or other key sites in the health neighborhood, like the criminal justice system. So I'm gonna buzz through the next several slides. With ask, you really only have one metric, and that's how many people did you ask divided by the number of people who should have been asked according to your eligibility criteria. Best practice guidelines say 100% of the people, 100% of the time. As I already said, that's not always a reality. Although I stress, you should try to give it a shot and see what the problem with achieving it is. Because no matter what limitations we set on our program at the start, 100% of the people, 100% of the time will always hang out there as a practice improvement goal. With advise, this to me is a no-brainer. 100% of the people who get a positive screen for tobacco use should get advice to quit. 100% of people who screen positive for tobacco exposure should be asked if there's something we can do to help them avoid that exposure, right? I mean, if you're not advising, if you're not at least advising, I don't know why you're asking. You may also measure who provides that advice. That gets us to that quality, the how are we performing this task. Ideally, the advice will come from the highest ranked healthcare provider the client sees. Now, obviously, in the health neighborhood, there aren't healthcare providers available necessarily. So in a site like a drug court, that person may be a public health official, right? It could be you. It could be a court officer, a parole officer, or some sort of admin, administrative assistant, administrator. In any case, we might want to make note of that if there are differences in the levels of people who could be providing that advice. A great metric to collect for assess, and one that has some actionable strategies associated with it, is the stage of change. The stage of change can be quantified in specific ways, I'll show you one later, to make it less subjective. And also it's a great way to begin tailoring our services so that no one receives so much attention that it backfires and wastes resources, but while also helping to ensure that everyone gets enough so that they don't have a bad quit that stalls the next quit attempt. Again, best practice guidelines are that we should assess the stage of change of everyone who uses tobacco, although that might not be a reality in your settings. This is the stages of change with a standard operationalization. They're based off of the quit timeline. When does the client want to quit? Another common way to do this is to divide up the a 0 to 10 scale, like for motivational interviewing, on readiness to quit, and sort of divide that up into really 4 categories of how ready are you to quit, where say 11, which is off the chart, is I've already quit, so what can we do about that? And that's your maintenance phase, right? Okay, so there are 2 major ways to operationalize the stages of change that are easy to categorize in EHRs or patient records. Okay, once we move into assess 2, I'm suggesting that this is greater than or equal to the contemplation stage and nothing below that. At this point, we'd want to assess their level of dependence. And again, we've covered these in previous presentations. If you are interested in adding this level of care, you can go to our website, download a real handy clinical guideline sheet that includes the questions associated with these scales and then how to code them, and then the inter-T dosage recommended here. You may also want to add an official diagnosis, because this can aid in billing and also aids in continuity of care, which is sort of critical here. And finally, in the assess 2 phase, you may want to decide to add some biofeedback options to this phase. This can give us data on the actual dependence levels that exist in your service area, and they can be motivational to your clients in their quit attempts. I probably said this the last time I brought up biofeedback, but especially within the criminal justice system involved population, we want to make sure that clients cannot be punished due to results that you provide via biofeedback. These are to be used for motivational purposes and not punitive ones. So if a drug court judge, for example, demands to see nicotine-free urinalysis as a program requirement, and then failure hits the client with a technical violation, then we don't want to add this service. We don't even want to propose that we do this. After you've done some assessment, even just the basic stage of change assessment, you can begin making an effective referral. And I'll return to that in just a second. But if you are going to provide more services, then you'll be going into the assist phase. And at this point, I would suggest that you don't engage a client on these issues unless they are in the preparation stage or later. At this point, you can measure, for example, how many of your preparation stage clients set a quit date. And this is actionable information. We know that clients who are willing to set a quit date are both more likely to make a quit attempt as defined by BRFIS, but they are also more likely to be abstinent in the long term. But I don't want that to be heard as then we should set a target on this metric, right? We don't want to turn this into a target, because causality could run both ways, right? It could be the case that clients who are more likely to succeed may be the ones that, for whatever reason, are less fearful or nervous or anxious about setting a quit date. That said, a client setting a quit date can be a potential measure of how motivating different caregivers are. So we can use it as that sort of metric. But perhaps more importantly, it gives us a date on which to follow up with the client, right? As seen here. And with a range, that a follow-up visit was set can be a metric, that a quit date was set, and that the clinic contacted the client on or around their quit date can be a metric. The time between follow-ups, the frequency of follow-ups, the duration of follow-ups can all be separately recorded as metrics on this 5th A. Follow-up may also mean following up with the client's referrals and or with consultations to other team care, other members of the care team. And then in our last bit here, I'm going to move into just a few systemic level changes. I'm running a little bit out of time. No matter what other changes you've made, they should all be protected via policies. But some of the things that you might want to look at are making sure that if the possibility exists of using electronic health records, that we are using them appropriately, that we're getting reports and audits and queries to sort of assess whether or not we're matching our service level provision with dependence level needs. Definitely be referring to the ASH line. There are a lot of things that you can do. This can be a standalone program all by itself, and there's a lot of things that we can do in terms of manipulating our approach and how we approach clients and how we do follow-ups and how we try to maximize what we would call conversion, people who are referred who actually get enrolled, okay? And then lastly, in this last bit, and I'm not going to dwell too much on these because like this first set, I already know you know about them. They are available on our resource site. Definitely get them. There are others that we provide freely to download. They're found in the resources section of our total website, our overall website. If you are thinking of a QuitLine or AshLine based program, and you're wondering like what are the concerns of people who you might refer, like how can you tailor your referral process so that it meets the needs and relieves the anxieties of the people you're referring, check out the report on the left. It's already available on our website, and Chad will have to tell us when the next one is available, this National Jewish Health Project. This one looked at rural users and rural non-users of the QuitLine, which I think is really cool. I think that may be available publicly as early as next week. It's relatively new, as you can see. Definitely head over to the National Academy's press website. Lots of free books there, freely to download as PDFs. If you want to buy them, most of them you can, but they're between 45 and 60 bucks normally. So I like the downloads. Particularly look at that third one. I think I've already sent it to some of you who've sent in questions regarding your programs, but a lot of really great information in there about what's happening in and out of reentry. Of course, I'm going to tell you to get the Surgeon General's reports. This is a no-brainer recommendation. I'm highlighting too, though, that red one, I think I'd mentioned before during one of our webinars or calls, that is brand spanking new. It came out in January. It's specifically on tobacco cessation, or smoking cessation. The first report on smoking cessation in over 20 years. The green one is from 2006, so it's a little old and some of the data in there is going to be outdated, but it is the only one that I know of where the Surgeon General comments directly on inmate exposure to secondhand smoke in any amount of depth. And it's actually really, really interesting information in there about the origins of that movement and some of the court cases behind it and some other things, if that's your bag. Of course, we also have some Arizona-specific resources. The first two on this slide, the left one and the center one, were recommended by y'all, and we really appreciate it. Those are up there, and I hope everybody's gotten a chance to see those. The third one I'll be putting up this afternoon. Chad also sent me a bunch yesterday that I will also be adding this afternoon. I just didn't get them in time to create new art for this slide. And then, of course, as always, check out the National Behavioral Health Network for Tobacco and Cancer Control. Lots of really great resources there and links to great new webinars, including, as I already mentioned, the one that Chad and I will be doing on QuitLines on Monday. And whew, all done. So a lot of comments and questions